Welcome, everybody. Hope you enjoyed the talks we just had, mine, and a very good talk by Dr. Abushahin. If you have any questions, please pipe up in the chat room section, and we'll try to keep up with the questions as they come in. I will start. There were a couple of questions that were texted while we were giving the talks. The first one in mine, one of the questions that came through was, what do you use beyond LonSurf? I think that's an open-ended question because it much depends on what you use prior to LonSurf. I think obviously for patients with KRAS wild type, you're going to use 5-FU based regimens with EGFR targeting agents, and for the mutations, you're going to go through the non-EGFR combinations. And unfortunately, in post-5-FU setting, the options have been fairly slim, and we've had regorafenib and LonSurf for a while. The data that's was published about 2 years ago, looking at the combination of LonSurf-Bev and the ongoing trial that's going right now in the recurrent setting. I have used LonSurf-Bev a number of times, but unfortunately, there's not a lot of strong data for anything in that setting once you get beyond the LonSurf and the regorafenib combinations. And I think that's a very open area in colorectal cancer and things we ought to be looking at from a clinical trial perspective. I think if you have specific mutations that may lead to certain targeting, whether it's a HER2 amplification or elevated HER2 on IHC, I think looking at other specific mutations to try to get people on trials with those mutations are also interesting cohorts. Unfortunately, there's just not a lot of strong data with strong trial data behind it for anything beyond those drugs in that setting.
Excellent. Now, John, let me ask you this. From a practical standpoint, when you see the patient with metastatic colon cancer for the first time in the clinic, what is the molecular testing panel that you would eventually get and base your treatment decisions on?
So I think that's actually a really good question, and I think one that changes about every year as we go through it. Over the last 5 years, it seems like every year we have new things we need to look at. In a frontline metastatic setting, we usually use a panel that looks at extended RAS, mutation profiling of KRAS and RAS. We also look at BRAF mutations and mismatch repair protein expression. I've also begun looking at HER2 expression at that point in time, just to try to get all of the information that we have in the upfront setting. I think how that is guiding our decisions is in the frontline setting is actually a tougher question. I think for the most part, we've all used 5-FU based combinations, either 2 or 3 drug combinations with FOLFOX or FOLFIRI or FOLFOXIRI. I think there are some new trials looking in the upfront setting for, say, BRAF mutations that could be interesting about what we should use as targeted therapies in the frontline setting. And obviously with the mismatch repair deficiencies, looking at immune-based combinations or immune therapy. I think the data from KEYNOTE-177 is pretty strong. And I think looking at the number of people that are progression-free years down the road is really compelling. And I tried to mention that in the talk. I think with immune therapy, what we've seen that we haven't seen in chemotherapy in a long time is that plateau effect of patients that are on therapy, and after a certain period of time, people just stop progressing, which is pretty amazing. And we've seen that in other diseases as well. And so I think that it'll be interesting over the next couple of years as we try to kind of more hone down on what is the right way to do immune therapy, whether doing it with single agent or in combination, frontline or second line. I'm an advocate for frontline at this point because I think one of the problems we have is for many of these patients, at least in KEYNOTE-177, 20% of the patients that were eligible for immune therapy never received it after the frontline or at any time. And so I think that that's giving those patients a disservice, unfortunately.
That's excellent. I think that there's a question in the chat that is in a similar category. What's the percentage of patients, colon cancer patients, who are MSI high?
So, obviously it depends on which data set you've looked at, but I think most of us would say somewhere in that, less than, right around 5% or maybe just a little bit over that for MSI high or mismatch repair deficient. My patient population, it's definitely skewed towards the younger patients that have those mismatch repair deficiencies. And I have a number of patients in their 20s, 30s, and 40s that have those deficiencies. And those are definitely ones we want to look at in the upfront or early on setting to try to get them on the best therapy we can early on. I think another part of that question looks at HER2 new expression and HER2 new mutation rates. That's also a very difficult question to ask. Almost all of the data we have in colon right now is for HER2 overexpression and looking at IHC. And I think one of the things that the Destiny trial was really trying to look at was, we know in breast cancer and to some extent in gastric cancer, what we should be using is our cutoffs, but that's never really been looked at in other diseases. And so I think one of the points of the trial was to at least have small exploratory cohorts in patients that have minor levels of overexpression to see if they might still have a response. And I think not surprisingly, those that have very little overexpression got almost no benefit from the drug, from the antibody drug conjugate. And those that had moderate expression got a little bit of benefit from the drug. And those that had fairly high expression are the ones that did well. I don't think we know the answer for HER2 mutations specifically, especially in colorectal cancer. And off the top of my head, I don't know what the mutation rate is in colon cancer, but I suspect that it's in the low single-digit percentage. But I just don't know that number off the top of my head. It's a good question.
I think it is a good question, and I completely agree with your answer. For the majority of the disease, as you know, the knowledge that we have about HER2 is about amplification,
yep,
which usually lead to overexpression of basically the HER2, eventually leading to enhancement of that pathway and growth and proliferation and whatnot. The rate of the mutation is exceedingly low, but the argument is that most of those mutations are what they call gain of function mutation, which usually would lead to a similar effect, the overactive pathway. So in theory, although that they actually could mean the same thing, it's always not the appropriate or the accurate thing to generalize what we know about overexpression to mutations. And now saying that I typically utilize anti-HER2 in these patients as just as a compassionate use, and I make it very known to the patient and everyone that this is an off-label use, because of the perception that it might actually do some effect.
So, and I think there's another open question that we don't know the answer to with HER2 is historically we've been looking at protein expression when it comes to classifying patients as high or low expressors, but now that most patients are being exposed to next-gen sequencing panels, we're learning that with message amplification and or copy number variation, what is the response rate to HER2 targeted agents in those subpopulations? And again, I think that's a question that we don't have the answer to, but is a really important question to look at going forward.
Excellent. So John, is it safe to say that you will offer immunotherapy first line to all MSI high patients, regardless of the genetic mutation?
So that's an interesting question. I have offered it first line, and I think with the presentations this summer, I'm probably more likely to offer it first line, because I think part of the information that we were looking at is how many patients would go on to receive it in the second or third line settings. I think the biggest question that we have in some of our patients is whether or not in a metastatic setting would those patients be able to get to a surgical resection. And in those cases, we look at response rates, and there are some regimens, some of the 3-drug combination regimens with a biologic agent that may have a higher response rate than single agent immune therapy in the frontline setting. And so in very, very select populations, I might try a 3-drug combination with a biologic as opposed to using immune therapy. But for most patients, I would stick to immune therapy in the frontline setting.
Excellent. And I think in the chat, there was a question regarding patients who receive perioperative chemotherapy with FLOT and then undergo surgery. They have residual disease, what to do at that point with immunotherapy versus continuation of FLOT. And obviously, this is a great question. The simple answer is no immunotherapy in that space. It's a little bit of a complicated answer, though. All of these treatments, whether it's cross-like FLOT or perioperative chemotherapy with FLOT and others, remain part of the standard of care of this disease. The advantage of one over the other is going to continue to be debated for a long time. Now, personally, I tend to try to harness the benefit of, or the advantages of all of the regimens at the same time. For patients who have distal esophageal adenocarcinoma and gastroesophageal junction adenocarcinoma, I started to use cross less and less with time, mainly because now we think it's comparable to a dated regimen, the perioperative magic-like regimens. So we do feel that it's a little bit, could be suboptimal for that population of patients. Now, I still believe in the role of radiation, though. And one of the things that I like to look at is building on the CLGB 80803 data. That was a phase 2 trial, and it wasn't necessarily a large trial, but it basically gave patients a period of induction chemotherapy. And then after that short period of induction chemotherapy, they would have PET CT scan, and that PET CT scan would be used to assess response to that particular chemotherapy backbone. And then based on that, patients would receive a response-directed chemoradiation treatment. For example, if they started with FOLFOX and then they were PET responders, they would receive 5-FU platinum radiation chemotherapy, while if they were not, they would basically switch to a carbotaxol radiation, and vice versa, basically. The advantages of this trial that it showed us that using a response-directed chemoradiation following a period of induction chemotherapy actually improved the outcomes of the majority of the patients. Both patients who are responding had excellent 4-year overall survival rates. The 4-year overall survival rate, for example, for the induction FOLFOX followed by chemoradiation was not reached yet. The median survival was not reached 4 years after the follow-up of these patients. Same time, what it showed us is that it improved the outcomes of the patients who are not responders, who historically would do actually bad, by giving them a different kind of chemotherapy that have a better chance potentially to improve their radiation sensitivity. You are keeping the component of radiation and local regional control and potentially utilizing a better chemotherapy regimen. Another advantage of using that regimen, for example, is that you still have patients who receive chemoradiation who, if they had residual disease after this, they would be candidate for adjuvant immunotherapy.
So there was another question that came up in the chat as well. In metastatic esophageal cancer, do you always use IO plus chemotherapy irrespective of CPS at this point in time?
Now, if the simple answer again is yes, but it's complicated. The simple answer is that this is currently approved regimen, the accepted standard of care in the United States of America for metastatic esophageal cancer, regardless of histology and regardless of the CPS score. Now, there are always caveats. I think what I do in my clinic is that I definitely give it with metastatic squamous, regardless of the CPS score, except in CPS 0 patients. I have a discussion with the patient. Same thing for adenocarcinoma patients with high CPS score. But in patients who have metastatic esophageal adenocarcinoma, who have a CPS less than 5, I tend to actually have that discussion with them, that the benefit of this additional medication is questionable, and that the toxicities exist, and that we wouldn't necessarily know. This is one of the points that are very important usually in this particular setting compared to others, is that we don't have the ability to know if it's adding value or not, because it's being used alongside a treatment that potentially could be working, which has an extended progression-free survival more than 7 or 8 months. So we wouldn't necessarily be knowing how much value it would be adding to the patient. And obviously some patients do have extra financial toxicities or side effects from adding immunotherapy. So I have that discussion with the patient about what and how much benefit is expected based on their CPS score, and we go from there.
Okay. There were a couple of other questions that came up about kind of early treatment in colorectal cancer. The first one is patients with high tumor burden or MSI high, should you go on chemo first to get a quick response and then switch to Keytruda? I think that's an interesting question. I think if you look at the data that's been published with 177, the response rates are not altogether different between chemotherapy or immune therapy. But if you look at the Kaplan-Meier curves, there's obviously a fairly sharp drop off in the immune therapy arm that actually causes a crossover event. Before you start to see that plateau. And so definitely people are progressing. Some patients are progressing fairly quick on immune therapy. I think that begs a larger question, is that while MSI high status and tumor mutation burden status are great biomarkers as a large population, there are definitely subsets within that population that respond very well and patients that don't respond very well. I have used, as I said, triplet therapy with a biologic to get a response if I'm trying to get somebody to a surgical endpoint, or if someone is very symptomatic from disease, because the response rates for some of the triplet regimens are higher than what's been reported, although they haven't been directly compared in a trial. The second question is on patients with BRAF mutations and first-line therapy. What would you consider triplet versus a doublet? That's also a very good question. I think the data would show that triplet regimens have a slightly better overall survival and response rate with triplet regimens in BRAF mutant cancers. And so for younger, healthier patients, I definitely will treat them with a triplet regimen up front if they have a BRAF mutation. The problem with the triplet regimens, as we all know, is the toxicity rates are significantly higher than with the doublet regimens. And so sometimes in patients that are a little more frail, I tend to hold off a little bit and maybe use a doublet regimen in those populations, or have the discussion with the patient about what the balance of quality of life may be. I think we're all going to be waiting to see what the Beacon-like regimens will look like in the frontline setting, and see if the benefit that we've definitely seen in the second and third line setting from the Beacon trial will translate into the frontline setting for those patients with BRAF mutations. I think another interesting question of that is if you look at the really small subset of patients from FOLFIRI that had BRAF mutations, I think it was only maybe 15 or 20 patients that were in that trial that had BRAF mutations, they still saw a 70 to 80% response rate with triplet plus panitumumab in that case, albeit the overall survival was still fairly poor in that population, as we've seen in BRAF mutant population colon cancer. So I will switch over. I don't see any other new questions coming up, so I'll ask a question and get Dr. Abushahin back to what he loves in pancreatic cancer. And so how do you choose who maybe gets Gem/Abraxane versus who gets FOLFOXIRI or FOLFIRINOX in frontline pancreatic cancer?
That's an excellent question. Obviously, whenever we answer this question, we have to think about therapy space for the patient, metastatic patients or perioperative patients. Now, speaking about metastatic patients, we had these two regimens now for almost 10 years for the FOLFIRINOX and 8 years for the Gem/Abraxane. We had looked at multiple ways of trying to select what do we start with. Most of the time, though, in practice, people usually tend to pick based on age, performance status, and toxicity profiles that are expected in these patients. We've looked at biomarker role for a long time, initially with the HEA1 and then with SPARC. Nothing really panned out, but there are things that should make or take a place. The thing that is currently validated is the presence or absence of DNA damage response defects. DNA damage response is about 16 different proteins, that the most famous of them is BRCA. That these mutations lead to increase or problems with DNA damage repair. And because of that, these patients are different in prognosis. They respond favorably to platinums, in addition to their response to PARP inhibitors in maintenance setting. Because of that, it is basically part of the good clinical practice is to obtain molecular profiling for all patients who have come with pancreas cancer metastatic disease. If they actually do have DNA damage response defect, we have strong data from the Know Your Tumor data that platinum first line would do way better in terms of survival compared to non-platinum first line for these patients. So that's why everybody who comes into clinic gets the testing for the presence or absence of these mutations. And if they do have those mutations, they should have a platinum-containing regimen. The most simple form is FOLFIRINOX dose modified, or gemcitabine and cisplatin. Now, outside of that group, at least till now, there is really no evidence of superiority of one regimen over the other in this space. There has been a lot of real-world case series that looked at this before. None of them really showed superiority of FOLFIRINOX. Sometimes I actually get a little bit irritated by the general perception that is available among or present among oncologists that FOLFIRINOX is superior to gemcitabine and nab-paclitaxel outside of the DNA damage response group, which I really don't think it's warranted. There has been no trials comparing them head-to-head in the metastatic setting. It is currently being compared to a certain degree with the NAPOLI-3 trial using the non-liposomal irinotecan and FOLFIRINOX basically. But at least till that happens, we really don't have any comparison in the metastatic setting. And we have two comparisons now in the perioperative setting, one of them in the resectable space, small trial, and the other one is in the locally advanced space, which we talked about today. And both of them really are not showing any superiority of FOLFIRINOX over gemcitabine and Abraxane in those spaces, and sometimes numerically favoring gemcitabine and Abraxane. And this is just more of a personal view. I always say that FOLFIRINOX had two big advantages over gemcitabine and nab-paclitaxel. Always 10-year younger patients in general. And then we have the 20% or so that have DNA damage response that have a better prognosis when they start on platinum, but still really didn't show that superiority over gemcitabine and nab-paclitaxel, which argues that this question or that perception that FOLFIRINOX superiority should be revisited. The reason that this becomes an issue is that the majority of the trials in the United States for metastatic disease or perioperative would include or could include gemcitabine, nab-paclitaxel, backbone chemotherapy, and I have seen it in the past where this lead to reduced enrollment in those clinical trials because of the false perception that FOLFIRINOX is superior.
There are a couple of questions that came up of what do you use in BRAF mutant colon cancer after third line or after a beacon type regimen, and I think it also ties in for me with what you use after Lonsurf. There was another trial that neither of us really talked about that was presented in the plenary sessions. It was just talking purely about clinical trial enrollment. It wasn't talking about anything specific about a disease, but colorectal cancer was one of the large chunks of it. And when you ask me what I use third line BRAF mutant, if they're healthy enough, I will put them on a clinical trial if I can, because in that setting, we just have very little data for anything else. And I think one of the take-homes from this talk was that only about 14% of patients or 15% of patients with metastatic colon rectal cancer ever have a clinical trial even discussed with them, much less being enrolled on a clinical trial. And I think that's a travesty. In colon cancer in the upfront setting, we have very good options, but once you get past second and third line setting, the options have diminished in benefit. And looking at clinical trials in those settings is certainly an appropriate thing to do. And I would love to be able to see that we can get our clinical trial, at least discussions up to half of our patients at least, and hopefully we can get a quarter or more of our patients on trials if they're eligible. And I think that's my own personal bias, as we all like to say we have those things, and I love getting patients on trial whenever I can, and I think that that's a huge benefit that we can offer our patients if possible. There was another question, if we use Gemabraxane first, for whatever reason, can we still use FOLFIRINOX in the second line setting? What are your thoughts on that?
This is all driven by the patient's clinical status. The simple answer is yes. Now, do we need to use FOLFIRINOX as a triplet chemotherapy regimen? Is that actually superior over exposing the patient to fluorouracil, platinum, and irinotecan over their treatment course? That's, I think, unknown. It's common practice for me to actually, if the patient started on Gemabraxane, that they would go into a Naliri or a FOLFIRI-like regimen in the second line, as it's in the standard of care, and then a platinum-containing regimen in the third line, as long as there are no other active clinical trials that those patients are receiving.
Mm-hmm. Well, I want to say thank you. Our 20 minutes has flown by. I want to thank you so much for your time, Laith. And there's now time for a quick break, and I encourage everybody to go to the Engage and try to win giveaways that are being offered for the meeting, and go to the exhibitor hall and go visit some of the exhibitors and the good sponsors for this meeting. If there's any other questions you have, I think we're both open to be contacted at any time. And thank you for your time.